Let's now discuss your responsibilities when preparing the patients for PCI and or CABG. CABG stands for coronary artery bypass grafting. PCI again is the gold standard for treating MIs. So it's interchangeable. You can call them PCI. The technical term really is percutaneous transluminal coronary angioplasty. So this is with or without stenting, meaning they can open the one or more coronary arteries with the balloon, and they may or may not leave a stent to keep it open. So let's look at first chart 23-10. These are your post MI teaching, meaning lifestyle changes that the patient who was fortunate to have survived a heart attack that they must make in order to stay healthy. Now, take note that these patients are at risk for fatal dysrhythmias. So let's say somebody survived a STEMI. You had a STEMI and then you survived a massive heart attack. Now you have a high risk for a fatal dysrhythmia because of the dead portion of your ventricles, of your myocardium. Those cells that don't have muscles anymore, meaning they have scar tissue, they are very irritable and they are prone therefore to either VTAC or VFib. Plus these patients are guaranteed to have heart failure. I mean, part of your heart is scar tissue. It died. So therefore you are in heart failure. So medications for heart failure will be prescribed, which we already discussed. And of course, we have to add diuretics there. All right. I won't read it for you. Okay, this is good. Select all that apply question. Again, activity is tailored to the patient needs, including sexual activity. When to call 911. Again, here, when do we call 911 again?
After the first.
Okay. After the first nitro, wherein there's no relief. So here's the description. So we call a die. Let's go to this is the description of the procedure. Okay. So it's nice to know. I'll go straight to your responsibilities. So what do we do before and after the procedure? Before, it's not really very complicated. So you prepare the patient the same way as you would prepare any pre-op patient. The NPO status here is not really crucial because did we have time to keep the patient NPO? No, this is occurring at any time. So whether or not they had a full meal, the patient will go to the cath lab. Now, the important thing here is education. What do you tell the patient to expect after the procedure? Now, if it's a STEMI, of course, you have a very short amount of time to do the teaching. For NSTEMI, however, you have a few hours. Okay, so you can do better teaching for the NSTEMI, not so much for the STEMI patient because we're in a hurry. But tell them about what to expect after the procedure, what activity level. Now, since I mentioned that we now do the radial artery approach, we no longer do it through the femoral artery. So there's really no activity restriction. Patient is up ad lib as they're tolerated. So they are strong enough, get them out of bed. Okay? After the procedure. So pre-op, again, depends. If it's an NSTEMI, yes, we have time, so you can bathe the patient, right? You can wash them with chlorhexidine, because it's NSTEMI, so we had time to prepare. For STEMI patient, there's not much. I mean, you wouldn't probably even see the patient. Okay, so probably you get to hang the heparin and or the nitroglycerin, but then shortly after that, they'll be out of off your floor. The cath lab will come pick them up already. So here's the post-procedure. So if it's the radial artery, again, up ad lib, ambulate as tolerated as soon as possible. If it's femoral, however, they will be on bed rest for as short as possible. Used to be before we put them on bed rest for 8 hours. I mean, what do you see wrong there? Post-op patient, you put them on bed rest for 8 hours. DVTs, right? So complications abound if you put anyone on bed rest. So that's why we no longer use the femoral. But if the patient did get a femoral, bed rest now is down to like 4 hours. But your responsibility is always the access site, because it was a huge catheter that they inserted through the radial or the femoral artery. So always watch for a hematoma. We call them pseudo aneurysms. They're not really aneurysms, but we call them pseudo aneurysms, meaning they'll grow a hematoma this big. Okay, so watch the access site. It's not very common, but it can occur, especially if the patient was on anticoagulants prior to the procedure. And if there is a pseudoaneurysm, we use mechanical compression. So this one is used for the radial artery, or if it's the femoral, then we use the femstop. Let me show you what a femstop looks like. It's basically, you know what a blood pressure cuff is, yeah? Mm-hmm. So it works the same way. So here's what it looks like. So it has a half circle, like a half of a ball, like this. So you turn this upside down, you apply that. Here's a better picture. So you apply this, see this dome shape? You apply that over the femoral artery. And the whole thing has a strap. You put this around the waist. And how you tighten it is you inflate the device. So just like a blood pressure cuff, so you keep inflating until it tightens. And of course, your key here is because you're compressing the affected femoral artery, then that means you have to check for the distal pulse. So you check for the pedal pulse as long as, or posterior tibialis, whichever one's easier to palpate. Make sure you can feel that pulse, because if there's no tibialis pulse, what did you do to the femoral artery? The compression was too much. Okay, so we don't want that. We want enough compression to stop the bleeding, because a pseudoaneurysm is basically bleeding. Okay, so the patient is bleeding out of there. The only difference is the bleeding has nowhere to go because the skin is intact. Okay, but the artery was punctured. Okay, so it's bleeding but has nowhere to go. So it'll be like this big. Okay, so we put the femstop over the artery and make sure again there is a distal pulse. Okay, that tells you that you just have enough compression, not too much. No pulse, then loosen it. So that's your responsibility. With every vascular procedure, always look for a distal or peripheral circulation. So check the color, temperature, sensation, and motion of the distal, especially pulses. Most people with NSTEMI go home the same day. And here are your complete complications, table 23-3, and your nursing responsibilities. MI, that's what you do. Now, the procedure can also cause an MI, okay? Meaning during the cath lab procedure, PCI, the patient may suffer a second or even a third heart attack. during the procedure. So we already discussed the bleeding and the hematoma. Again, the hematoma is usually a pseudoaneurysm, retroperitoneal hematoma, so meaning around the kidney area, arterial occlusion. So here's the pseudoaneurysm, AVF, or if there's enough blood loss, then there could be AKI. Any question on PCI? All right. Go to the last. Now, patients who qualify for CABG are the following. So indication is we attempted PCI. It didn't work. Okay, we were unsuccessful for one reason or another. Maybe the artery is too small, or maybe we had bleeding from the PCI, whichever reason. I mean, we couldn't proceed with the PCI. Another is if it's the left main coronary artery or multivessel. Now the LAD, which is your left main coronary artery, this supplies the left ventricle. So do you want to take the risk here? All right. So, or if it's multivessel, meaning usually it's more than 3, because we can still PCI, we can still stent 2, but if it's 3 or more, you're better off with a CABG, to bypass. And then preventing these complications, or again, an unsuccessful PCI. Show you the picture. So when we say bypass graft is, we're going to change since again, so let's say you have multivessel disease, right? So instead of, let's say, so this is the LAD, left anterior descending coronary artery, supplying the left ventricle. And there's your blockage there. So they're going to put a stent. So this illustration here is using the mammary artery. Or they can also do a lesser used internal thoracic artery. So we actually, no, it's the same. I didn't know that. Okay, so we use the mammary artery. The beauty of the mammary artery is you don't have to stitch it to the aorta. It's already connected to the aorta. So all you do is pluck it out of the breast muscle and then put it into the coronary artery. Okay, so less bleeding. Plus it's an artery, so better than a vein. The other option is using a vein from the leg. Vein harvesting is easier now. Used to be, the doctors usually slice the entire leg from the inner thigh down to the ankle to harvest the vein. Now we only make 2 1.5-inch incisions. So we'll cut here, and then harvest the vein endoscopically. Okay, so very minimally invasive now. So we develop better techniques now. Don't worry about the vein. Yeah, we lost the vein, but the patient will grow new ones. Plus, there's collateral circulation anyway, right? It's not like this is the only vein in the leg. Okay, so we have the saphenous, we have the lesser and the great saphenous. We also have the popliteal. Okay, so we have several options. So they'll just choose which vein is best, and then they'll use that as the graft. No. We can grow new capillaries, but not veins. Now, as to which vessel is used, the doctor and the patient will discuss it. They also consider the age of the patient. So if there's a younger patient, which one's better, a vein or an artery? A younger patient. Artery, because they're expected to live longer. So we need something that will last as long as the patient's life expectancy. So it's an older patient, we can get away with
So what
a vein.
happens if they lost the mammary artery? What happens to the mammary gland?
Again, that's not the only supply to the breast muscle.
Oh.
Okay. So we have, again, other collateral circulation. So this one, again, is best for younger patients. So imagine how this is done. So can you have although I shouldn't say that, they can do it now, meaning they don't have to stop the heart when they do this procedure now. Before, they have to stop the heart, meaning we have to circulate the patient. We have to use a heart-lung machine, meaning we have to divert blood out of the body, oxygenate it outside the body, and then return it to the body. All right. So if that's still the technique used, then of course, expect a few tubes coming out of the patient. Okay, so let's say they use the traditional CABG approach, meaning they stop the heart from beating. So they use the heart-lung machine. So after that, expect 3 tubes coming out. The first 2 tubes are mediastinal tubes. You know, chest tubes? We discussed chest tubes last month. Yeah, we did. Lab, yeah. Yeah. We did chest tubes, right? Okay. So same chest drainage system, but the tubes here, of course, are smaller. So there will be 2 coming out of the mediastinum. So there's an open chest incision, right? So there will be 2 tubes connected to a chest tube, a chest drainage system. Okay. What is the purpose of that tube? What did they do here? They sliced the heart. So they opened it. Of course, there'll be bleeding there, right? So if you don't drain that blood, what will happen? What will develop? What do you call that? Not pericarditis, but the complication. Cardiac tamponade. Okay. So is it important to make sure that those tubes are patent, that they're draining? What are those 3 signs again of they were called the Beck's triad? Symptoms of cardiac tamponade: hypotension, muffled heart sounds, and distended neck veins, or JVD. All right, so you watch the patient. The third tube will be the pacemaker. There'll be pacemaker wires, because remember, we stop the heart, right? So for the next 24 to 48 hours, expect a external pacemaker. It's just to make sure that heart beats correctly, right? So those are the 3 tubes you'll be expected to come out of that external incision. Okay. Reassure the patient. There's several pain medications here. Okay, so patients may get a PCA. Okay, so they'll be pain-free. Again, very nice room, like the Waldorf Astoria. Okay, and they'll have short nurse-to-patient ratio, and there'll be hypothermia will be induced. This will allow the heart to rest. And this is the cardiopulmonary bypass machine. So we cool the patient to reduce myocardial oxygen demand and also reduce heart muscle activity.
So the tubing thing is different from ECMO? Or is
Similar. So this is the setup. So this is how they divert your circulation outside, you know, the circulation and the oxygenation. We won't discuss the other procedures. We'll just stick with the traditional CABG and PCI. Okay, last topic is the complications. Table 23-4. So blood loss, I had this on the quiz earlier, right? We had a quiz question. Bleeding, of course. Cardiac tamponade. Again, remember the Beck's triad. Fluid overload because we do have heart failure here, risk for heart failure, plus the patient will receive IV fluids. Hypothermia, especially during the procedure when we bypass the circulation while doing the bypass procedure. And dysrhythmias, including bradycardia. Or they could have another heart attack. And here are your pulmonary complications. These are rare, by the way. These are not common complications because these doctors prepared in advance. All right, they prepared, they practiced, they make sure everything is good because it's not good for business. So let's say if they get one fatal complication out of these cases, it's bad for statistics. Okay. So usually what happens is if let's say they have a very high risk patient, right? So they don't recommend the procedure, but the patient insists. Okay. So yeah, I'll take the risk. Okay. So let's say the prognosis is poor. They say they doctors decide this is not going to be a good outcome. Okay, but the patient, they can't refuse the patient. Okay. Patient says, I still want it even with the risk. Okay, either the patient or the whoever's the decision maker. What they'll do is transfer that patient to another facility. They'll still do the procedure, but at another hospital. Why? The statistics. Again, bad for business. So let's say Northwell is where that doctor works, but he has privileges to, let's say, at Bellevue. Okay, we'll do your procedure. We'll do it at Bellevue. Okay, so yeah, so if there's a mortality, then it's in the Bellevue record. Okay, so Northwell remains flawless.
So the doctor, even if the doctor was caring for that patient that happened under his, he could still.
Yeah, because the record is on the facility.
So they don't care about the person that did it, they care about where it was done at.
And here, so as with any other bleeding, blood loss, of course, there's pre-renal AKI, correct? Or like, it could be also from the dye, from the PCI, so that could be intrarenal. Let me see if we finished. All right, so here are your tubes. So you've got two mediastinal tubes, and then you have the pacemaker wires. And you may definitely have a Foley here because we need to measure hourly urine output to ensure that there is adequate cardiac output. The chest incision is usually, you don't need to change this because they have 7-day or 2-week dressings now. They stay in place. I mean, it's hard to take off, and it's better with these types of dressings. Okay, you don't see you see the staples. The staples will just come out after 10 days. So they'll remove the 7-day or the 10-day dressing, and then they'll remove the staples. Other complications, these patients may throw clots. So besides a heart attack, patient may get a stroke as well. Again, these are rare, right? That's it.